diabetes and obesity. But certainly, as we will see in the next few minutes, there are more news and definitely evidence for additional benefits from these drugs. So it looks like we are really living a golden era in terms of news for diabetes and obesity therapy. These are my disclosures that I am always pleased to share. And this is a kind of traditional slide in which we recall what we can build on the actions of the GLP-1, because obviously this is where we are starting from. GLP-1 is a prominent agent to stimulate insulin secretion, to suppress glucagon, to also regulate blood pressure by improving natriuresis and diuresis. It does, as we know very well, suppress appetite and cause weight loss, but it does also have important effects on cell survival. So this has been apparent in the favorable changes of multiple intermediate parameters, including inflammation, coagulation, postprandial lipids, heart function, and the survival, as I alluded earlier, of beta cells and other cells, including the neurons, translating into benefits that we know very well and are already largely established, not only the metabolic effects, reducing HbA1c and body weight, but also effects on cardiovascular risk factors like blood pressure and albuminuria, and particularly the reduction of cardiovascular events. So it looks like GLP-1 is an important brick on which building additional benefits in terms of therapeutic agents. And this concept has been exploited with the addition of other receptors that are very similar to the receptor of GLP-1, which represent the targets for the future therapies or the therapies under development. So in addition to GLP-1, we have the GIP receptor, the receptor for glucose-dependent insulinotropic polypeptide, and we have the receptor for glucagon. And you can see in this beautiful slide depicting the extracellular domains of these receptors that they are kind of similar. They have important areas of similarities or homology, which represents the basis for using a single molecule to activate more than one receptor. And this is what has been done with tirzepatide. It is a single peptide that is more close to the structure of GIP than the structure of GLP-1, but it does have the ability to target and activate both the GIP receptor and the GLP-1 receptor. Now, we have recently conducted, a few months ago, was published in eClinical Medicine, a network meta-analysis trying to compare with this indirect statistical approach the efficacy of GLP-1 based therapies. So we consider tirzepatide because, of course, it's a GLP-1 based dual agonist, which also activates the GIP receptor. We consider the combination of basal insulin and GLP-1 in the fixed ratio combinations IDEC, LIRA, and IGLA-LIXI. We consider the combination of GLP-1 and SGLT2 inhibitors, which, of course, have a series of complementary benefits in terms of their mechanism of action and effects. And we also looked at the high-dose GLP-1 receptor agonists, which is something that we will again talk later, but are already available in some countries. You know, for example, the 2 milligram dose of semaglutide, or the 3 milligram or 4.5 milligram dose of dulaglutide. As there are no direct comparisons among these therapies, we constructed a network of the studies, and we perform the indirect comparison with this approach that I mentioned, the network meta-analysis. So it turns out that tirzepatide is the most efficacious agent in terms of reducing HbA1c. The efficacy is greater as compared to fixed ratio combinations, as compared to the combination of SGLT2 and GLP-1, as compared to the high-dose GLP-1 receptor agonist. So definitely we are seeing in the countries in which this drug is already available a greater opportunity to correct hyperglycemia. And we know that, as already discussed previously, looking at the data from the SARPAS program, we know that this very high efficacy of tirzepatide translates into a relatively large proportion of patients who achieve an HbA1c, which is basically normal. So they achieve normal glucose levels. This proportion with the highest dose of tirzepatide across the SARPAS program ranges from 30 to even 60% of the patients. So there's a very important likelihood that people, regardless of the duration of the disease and concomitant therapy, people treated with tirzepatide may achieve normal HbA1c levels. And this is more likely to occur, as it was shown in a recent analysis from the SARPAS program, in people who are younger, who have shorter duration of diabetes, have lower baseline HbA1c, and do not use many drugs. For example, they only use metformin as another anti-diabetes agent. So these individuals are those that achieve normal glucose levels, normal HbA1c levels, and this, as I mentioned, overall occurs in about 35–40% of the patients. Not only efficacy on glucose lowering, but also very high efficacy in terms of body weight reduction. This was again shown by our network meta-analysis. Tirzepatide, especially at the doses of 15 and 10 milligrams once weekly, is more efficacious than any other strategy in terms of reducing body weight, including the high-dose GLP-1 receptor agonist and the combination of SGLT2 inhibitors and GLP-1 receptor agonists, which I think is an important concept, because it tells you that by targeting two incretin receptors, you can be better off in terms of weight reduction as compared to using a high dose of a GLP-1 receptor agonist, or also as compared to trying to target body weight excess with the combination of an SGLT2 inhibitor and a GLP-1 receptor agonist. And importantly, this occurs regardless of extra problems in terms of tolerability. Nausea and vomiting are very similar with tirzepatide as compared to GLP-1 receptor agonists, even when used at high dose. So I think this is important. The efficacy tolerability ratio of tirzepatide is more beneficial, probably because, as we know, targeting the GIP receptor provides improvement in terms of nausea and vomiting, and even some kind of mitigation of the nausea and vomiting, which can be caused by targeting the GLP-1 receptor. So these new injectables that target multiple receptors are definitely providing some interesting new benefits in terms of clinical outcomes. The extent of weight loss is also something we have to consider, especially for the future, because we learned from studies with bariatric surgery that in people who have a shortened duration of diabetes, less than 5 years or 6 years, it is sufficient to achieve a 10 to 15% weight loss to improve and reduce the content of fat in the liver and pancreas, to improve insulin resistance and also beta cell function, and therefore to achieve what we call remission of hyperglycemia in people with type 2 diabetes. Probably in people with more advanced disease, you would need a higher extent of weight loss, ranging from 20 to 25%. But definitely, you know, as already shown for the studies with tirzepatide, people who are younger, who have a less high HbA1c, who use fewer medications, who are not on insulin and have a shorter duration of the disease, might be better off in achieving this so-called remission of hyperglycemia. So with these new drugs that promote weight loss to a very high extent, like tirzepatide, I think, you know, we could experiencing this process and these kind of results more often in the future. But another important aspect, which is not yet totally addressed, is the potential benefits on cardiovascular events of these dual agonists, such as tirzepatide. We know, as we just saw, that tirzepatide has the ability to target the cardiovascular risk factors with a very high efficacy, even when compared with semaglutide, for example. We saw already the data on HbA1c reduction. Here you see the data on insulin resistance measured by the HOMA-IR index. There is a greater effect of tirzepatide on systolic and diastolic blood pressure, especially the high dose of 15 milligrams. There are, as we have seen already, greater reductions in body weight, in waist, and shown here in liver fat, for example, or in visceral fat. And in this other slide, you can see how also the lipid profile is ameliorated more definitely with tirzepatide as compared with other drugs such as semaglutide or dulaglutide. And you see on the right-hand side of the slide a very prominent effect also on the reduction of CRP and adhesion molecules, which are important for atherosclerosis. So tirzepatide has all the basis for being a drug that, like GLP-1 receptor agonists, such as liraglutide and semaglutide and dulaglutide, and also albiglutide or epiglenatide, have shown to reduce the cardiovascular events. But we need to listen from the results of the SURPASS-CVOT, which is a trial currently ongoing, which will look at the cardiovascular events with this particular GLP-1 GIP dual agonist. In the meanwhile, we can also appreciate how tirzepatide, with these prominent effects on cardiovascular risk factors, but also by exploiting the GLP-1 receptor based direct effect on the kidney, could be also beneficial in terms of slowing of CKD progression in people with type 2 diabetes and reducing also the albuminuria or the slope of eGFR, which is something that we have already seen in some trials as a secondary or exploratory endpoint. So tirzepatide will in the future likely grant us with some additional evidence in terms of remission of type 2 diabetes, of reducing cardiovascular events, and reducing the CKD. I mean, of course, this has to be proven more definitely, but there are already some important results that make this scenario relatively likely. As we move on to other injectables in type 2 diabetes, we cannot, of course, ignore that there are already important developments by targeting all three receptors, the GIP receptor, the GLP-1 receptor, and the glucagon receptor, with drugs such as retatrutide, again, a single peptide which has been engineered in order to bind and activate all three receptors. Retatrutide, therefore, brings about the benefits of GLP-1 action, the benefits of GIP action, and the benefits of glucagon action, which I would like to remind are also in terms of reducing appetite, in promoting energy expenditure, and improving liver fat content, reducing liver fat content. And retatrutide is a C20 deacylated peptide that binds albumin with high affinity So it is also once a week administered drug. It does have different affinity towards the GIP and the GLP-1 glucagon receptors as compared to the native ligands, but it is overall, as we will see, a drug able to activate all three receptors and promote the action of three hormones. So retatrutide has been investigated in a phase 2 trial conducted entirely in the USA, one in type 2 diabetes and another one in obesity. You can see here the data in type 2 diabetes in terms of HbA1c reduction and the comparison with the 1.5 milligrams dulaglutide. So the higher doses of retatrutide, namely 8 and 12 milligrams once weekly, are more efficacious as compared to dulaglutide 1.5 milligram in reducing HbA1c and also in achieving the glucose targets, the HbA1c targets of less than 7% and less or equal to 6.5% or less than 5.7%. We're about we see about 30% of patients that achieve normal HbA1c with retatrutide. A little bit less, I would say, as compared to tirzepatide, but this is data in a relatively smaller number of patients and is a phase 2 trial. So we have to see additional data. What I think is definitely more prominent in terms of the clinical profile of this triple agonist is the effect on body weight, because you can see that after only 36 weeks of treatment, people with type 2 diabetes lose more than 15% of their initial body weight, and they achieve significant and large extents of weight loss. So, for example, people who lose at least 15% of their initial body weight are more than 50% of the patients. And there are about 40% of patients who lose at least 20% of their baseline weight. So this is, I think, a profile that tells us this drug could be particularly beneficial in terms of reducing excess body weight in people with type 2 diabetes, and very brilliant data are also available in obesity. Another approach which combines two injectables in targeting metabolic diseases is the one that includes administering semaglutide at the dose of 2.4 milligrams, which is the highest dose approved for the treatment of obesity, and cagrilintide also at the dose of 2.5 milligrams once weekly. And cagrilintide is an amylin analog. So this study is also quite recent. It was conducted in people with type 2 diabetes. It's a phase 2 trial with an HbA1c at baseline of 8.4% and the body weight a bit higher than 100 kilograms. People were on metformin and some of them also on SGLT2 inhibitors. And you can see that as compared to the individual components of this combination, namely semaglutide and cagrilintide, the combination of the two drugs given once weekly was able to promote an HbA1c reduction of more than 2%, which is, I think, a very bright result, and especially to reduce body weight by more than 15%. So results that are resemblant of those that we just saw with the retatrutide. So again, we have probably another approach which is even more efficacious than tirzepatide in promoting weight loss in people with type 2 diabetes, as well as not shown here in people with obesity. So this concept was very recently addressed and explored and expanded, I would say, in a very nice review article by the group of Melanie Davis, that we have to build upon the GLP-1 agonists. We have to consider all of the benefits that we can achieve with the GLP-1 receptor agonist, but we can add to that the action of GIP, as nicely shown by what was achieved with tirzepatide. We can exploit the triple agonism, adding also the activation of glucagon to that of GLP-1 and GIP receptors. We can use some additional targets in this context, like PYY or amylin agonists, as we have seen with cagrilintide, in addition to semaglutide. So this was very nicely described in the context of obesity treatments, but obviously these drugs are in most cases also investigated in people with type 2 diabetes because of their glucose-lowering effects. So the last part of my talk is in regard to something that is not injectable, because I think, of course, we have all these news about peptides that can be injected subcutaneously, even once a week, so very conveniently for the patient. But we should not forget that there are some efforts in terms of pharmacological research trying to develop some agents that would work similarly, but without the subcutaneous injection. So I would like to very briefly mention here the high-dose agonists like oral semaglutide, and the non-peptide agonists like orforglipron, which have been recently characterized also in clinical studies. Here you see the Pioneer Plus program, which is a program based on the data with oral semaglutide, but the doses here are elevated to 25 and 50 milligrams once daily, so much higher than the 7 and 14 milligrams that we currently use for people with type 2 diabetes. Trying to investigate whether by increasing the dose of this oral GLP-1 receptor agonist, you could have an increased efficacy in terms of both HbA1c reduction and body weight reduction. And this is the case. So as compared to the 14 milligram dose, the 25 and 50 milligram dose reduce HbA1c to a greater extent, so about 2% less than baseline. These people were with an HbA1c baseline of almost 9%. But I think especially on the body weight reduction, you can do much better with the loss of 7 to 8 kilograms as compared to the 4 kilograms of the 14 milligram dose. And again, these people were with a baseline weight of about 96 kilos, so they were largely obese. So there is evidence that increasing the dose of oral semaglutide results into additional benefits on both hyperglycemia and excess weight correction. But I think the most interesting part here is this orforglipron, which is a non-peptide GLP-1 drug. The fact that it is based on a peptide structure is quite interesting, because obviously, this enables orforglipron to be administered without particular attention to food or other drugs, as it is currently the case with oral semaglutide. So it can be given with meals, without meals, with other drugs, that there would be no issues in terms of absorption and bioavailability. And the other thing is that orforglipron is a GLP-1 receptor agonist, but it is called a biased agonist. So for some reasons that are not easy to be understood, but probably are due to the fact that the signaling of the GLP-1 receptor, when activated with this particular compound, is more persistent as compared to the native GLP-1. This translates into a higher level of efficacy. And you can see here how this drug, again, compared with the dulaglutide at the dose of 3 milligrams once weekly, is more efficacious in reducing HbA1c and is also more efficacious in reducing body weight. So I think we will have additional results and benefits from this oral non-peptide GLP-1 receptor agonist. So in conclusion, I think we really have new drugs on the horizon for type 2 diabetes, but also for obesity. We, of course, have results about high-dose GLP-1 receptor agonists, like the ones I just showed you about oral semaglutide at the dose of 25-50 milligrams. We have non-peptide GLP-1 receptor agonists like orforglipron and others under development. We can definitely further exploit the clinical benefits of tirzepatide, especially on type 2 diabetes remission, cardiovascular events, and renal outcomes. I did not talk about the dual GLP-1 glucagon receptor agonist, but definitely that's another area, as you have seen in the cartoon of the review by Melanie Davis, of development. We have multi-receptor agonists like retatrutide, which target all three receptors, including GLP-1, GIP, and glucagon. And we can think of combination multi-peptide approaches, for example, combining semaglutide with cagrilintide, which is an amylin analog. And we have even many more of these combinations or molecules activating multiple receptors. So this, I think, will provide an opportunity to treat patients to target with a higher level of efficacy, so a greater HbA1c reduction, but also, for example, greater time in range, as the CGM will be used to monitor the efficacy of these approaches, greater efficacy also in terms of weight reduction. And hopefully this will also translate into a greater benefit to our patients in terms of reducing the complications of diabetes, not only the microvascular complications, which are more related to the glucose control, but the pictures of organ damage, so cardiovascular disease, heart failure, metabolic liver disease, and all of this in the absence of hypoglycemia excess. And hopefully this will also translate into a greater level of satisfaction for our patients, because the studies sometimes are also including questionnaires to try to understand if the patient perceives the therapy as a beneficial one, as a convenient one. And the fact that we are always more and more towards weekly injections or oral easy to use drugs is not trivial and not secondary. It is part of the development of efficacious therapies that would provide also patient satisfaction, as well as achievement of glucose, weight targets, and organ protection. So I think we will have a bright horizon in the future for our patients. And with this, I close, and thank you very much for your kind attention.
Thanks a lot, Professor Gorginio, for this intelligent talk as usual. And there is a great hope for diabetes management and weight management and NAFLD and NASH management. I'd like to ask an American Thyroid Association the last year, the review take about the increased incidence of all thyroid cancer in patients using GLP-1 for more than 1 year. What's your opinion about this?
Yes, these are some reports that, of course, have been published and are based on reporting side effects using large databases. Obviously, one should consider the level of evidence for these results, which is not comparable to what was more accurately and rigorously monitored during the trials, the phase 3 trials. I have to remind everyone that in the SARPAS program, there were no cases of medullary or other kinds of thyroid cancer, and the levels of calcitonin were not increased by the drug. So, of course, we have to remain vigilant in terms of looking at what happens in the future. But so far, I think the evidence we have from the phase 3 trials is sound and does not suggest any signal for some worries in that particular respect.
Yes. Another question about the glycemic efficacy of triple agonist, retatrutide. When we compare tirzepatide with retatrutide in terms of glycemic efficacy, do you know that the glycemic, what is the reason of the glycemic efficacy in dual agonist more than the glycemic efficacy in at the regard the A1C reduction than the retatrutide?
This is a good point. Of course, we have to acknowledge that the data with tirzepatide are based on a comprehensive phase 3 program. So, thousands of patients have been treated with tirzepatide with different duration of disease, with different types of patients. And we have definitely a kind of sounder, I would say, level of information about the efficacy and the results. In terms of retatrutide, we have so far a single phase 2 trial. So it looks like, in that particular trial, the benefit was more brilliant, I would say, and I already mentioned that in weight reduction than HbA1c reduction. And it is possible that if you target the glucagon receptor, you do not, add much in terms of glucose lowering, whereas you may have additional benefits in terms of energy expenditure and therefore weight loss. We definitely, the glucagon receptor, if activated, will reduce ectopic fat to some extent. So that's also something that goes, in the direction of improvements more in terms of lipid metabolism rather than glucose metabolism. So that's one explanation. The other thing is that the dual agonist has a particular level of balance when you consider the activation of GLP-1 or the GIP receptor. And in retatrutide, you don't have exactly the same kind of ratio in terms of binding those two receptors, besides the fact that there is the effect of glucagon. So this, just to mention some factors that make the two drugs not totally comparable. So if there are differences, these could be definitely expected based on the qualitative but also quantitative difference of agonism versus the respective receptors.
Yes. Do you expect that this dual agonist or triple agonist will take recently, will enter recently in the approval for NASH? This week, if they approve the first drug for NASH, the remicetron, but this is another mechanism of action, like thyroid-like hormone receptor, act on thyroid hormone receptor. Do you expect that tirzepatide or retatrutide has been approved in the future for treatment of NASH?
Yeah, the area of NASH or MAFL as more recently defined. So in any case, the non-alcoholic metabolic liver disease, which is very frequent in people with obesity and in people with type 2 diabetes, especially if they are overweight or obese. This field is definitely evolving very rapidly, as you were saying just now. So we may have other targets. For example, the thyroid hormone receptor could be a target for improving the fat content in the liver. But there are also some quite, I would say, good data with tirzepatide, especially in one sub-study of the SURPASS-3 trial. The SURPASS-3 trial compared tirzepatide with degludec as basal insulin, and some patients underwent also an MRI of the liver, showing that versus baseline, there was a prominent reduction of the fat liver content with tirzepatide, much more as compared to what happened with the insulin therapy. improvement of glucose control with insulin also does reduce fat content to some extent, but definitely what was seen with the tirzepatide was much better, much more convincing in terms of reducing fat liver content. And in individual patients, really, you can see how the fat was all the place, in the liver, at the baseline, and then after 1 year there was almost no fat in the liver. So some individual patients respond very, very rapidly and very brilliantly to the effect of tirzepatide. Probably this is due to some effect related to the weight loss, because it is still under debate whether GLP-1 or GIP may have direct effects on the liver. Similarly, there is a sub-analysis of the study with retatrutide, looking at fat liver content and especially the levels of transaminases with this triple agonist, also showing very promising results in terms of reducing fat liver content and the level of transaminases with the triple agonist, as you would expect, because I mentioned that the glucagon receptor, when it is activated, does reduce fat liver. The glucagon receptor is definitely expressed in the liver. So in that particular case, there's also a sound basis for a direct effect of the drug on the liver.
Retatrutide is more promising in the field of NASH, reduction of the liver fat than other dual agonists. Yes?
Yeah, I think so. I mean, of course, we have to wait until the studies will be conducted and completed, but there's definitely an interest in that particular direction. Also, with the dual GLP-1 glucagon agonist, there was one cotadutide which was discontinued, but others are under development. And one of the endpoints being assessed is the fat liver content.
The last question, as regard data you show, a comparison between different injectable. One arm includes GLP-1 plus SGLT2, which is an oral, and has a good result as regard the A1C reduction, as regard the weight loss. This explained by the synergism or complementary mechanism of action between SGLT2 and GLP-1. SGLT2 have minimal weight loss, about 3 to 4 kilograms, but either the area different will compare to the GLP-1.
Combining SGLT2 inhibitors with GLP-1 receptor agonists has obviously a lot of advantages in terms of metabolic outcomes, and we know also in terms of cardiovascular and renal.
And regard the weight.
For the weight, you are right that these are complementary and potentially even synergistic effects, because the GLP-1 reduces calorie intake, whereas SGLT2 favor calorie loss through the urine. Nevertheless, I have to say I was a little surprised to see that, as I showed you in our network meta-analysis, the extent of weight loss with the dual GLP-1 GIP agonist tirzepatide is greater as compared to the combination of SGLT2 inhibitors and GLP-1 receptor agonists. So even though we are talking about, in both cases, combining a different mechanism or similar mechanism, but with different, molecules.
The same result with all GLP-1, or it is different once daily or once weekly? It is a different, the same result is with all GLP-1, or what is the difference?
Well, we did not. I mean, there are not so many studies that allow us to really compare SGLT2 plus. So, for example, if you were to consider the high dose GLP-1 receptor agonist plus SGLT2 inhibitors, there are not studies that allow us to do that kind of comparison. So we are talking about the overall GLP-1 receptor agonist class combined with SGLT2 inhibitors. So it is possible to have a slightly better results if you were, for example, to combine an SGLT2 inhibitor with a high dose semaglutide.
Thanks a lot. Thanks a lot.
Okay.
Thanks a lot. I enjoy the lecture as usual. Enjoy the high caloric lecture. But you had experience in Mounjaro present in Italy?
No, not yet.
Not yet in Egypt. It is postponed because we have several economic problems postponed from the last month to about June or July to be. So you have no experience in practical use of Mounjaro.
No, I don't have. We have
present in the Gulf region, Saudi Arabia, but not present in Egypt.
Sure. Yeah, I know. No, we are really expecting, waiting with a lot of hope to be able to use it soon. It should come after the summer, hopefully by the end of the year. But
Yes.
it has been postponed many times. So we are even, having events with colleagues talking again about tirzepatide and all the new data, and then not yet. But I currently I am involved in 3 trials with tirzepatide. So one was completed, is SURPASS-3. Now we are also doing SURPASS CVOT and SURPASS Early, which is this trial using tirzepatide right after the diagnosis of type 2 diabetes. So we are
for the target of remission.
Yeah. Well, yes, to try
the target here is the remission. Yes.
Yeah, exactly.
Yes. Semaglutide 1 milligram is available in
we have semaglutide, but not a high dose. We have
not high dose.
No.
Ozempic is under the name of Ozempic 1 milligram not available.
No.
What is available in Italy? Liraglutide 3 milligrams Saxenda or
no, we have only for obesity. We have only Saxenda.
Saxenda only. Thanks a lot, and I have a pleasure to meet you again and to meet you. I'm looking forward to see you physically near in Egypt, inshallah.
Yes, I also hope we will have a chance to meet face to face soon in the future. Thank you very much.
Thanks a lot, Professor. Thank you.
Thank you. Have a nice day.
Thanks a lot.